Hello, everyone. I hope I'm audible and we're all ready to start. Um, is everything okay? Could you please, Mr. Muhammad, if you can hear me, just raise a thumbs up? Okay, great. So, this is Danielle Hachite, speech and language therapist from Maudsley Health by Makani. I'm pleased to be here with you today to talk about stuttering during uncertain times, to provide you practical strategies for parents and caregivers and even adults. So before we go ahead and proceed, may I ask if I have any one of us who's actually suffering from stuttering now on? Any one of us as attendees is currently stuttering? If you can give me a thumbs up or an eye in the chat. Okay. Does any one of us have a child who is currently stuttering and you're concerned about your child? Okay. So today we will be discussing stuttering in children and in adults. We will be giving you practical strategies and exercises by the end of the presentation. Initially, we will go through the theoretical part briefly and swiftly so that we can indulge in the practical part further. So our agenda for today is clinical foundations of stuttering, symptoms and triggers, some evidence-based practices and comprehensive assessment and treatment approaches that we use. Finally, some clinical applications that we will do together to support parental education and ask your questions and do some implement some strategies and practical tips. Before we proceed with explaining and defining stuttering as a disorder, I would like to introduce to you normal developmental disfluency. By the age of 2 to 5, children would go through this typical developmental disfluency due to their outburst in language. So they will be start to formulating syntax that is difficult for them to cohere together, grammatical structures that they want to build, and then during this age from 2 to 5, they will have some sensory motor coordination difficulties to articulate whatever their thought is due to this explosion in language. So we would see some features like stopping, interrupting, and then rephrasing the sentence like I want to go to the mall. These typical features are normal. There's no need for us to seek any support or go for any therapy. It will fade and the child will develop by the age of 5, the fluency will be normal without any interruptions. Key signs in this developmental stage is that the children are comfortable, they're relaxed, no signs and symptoms of frustration, no physical tension, they're comfortable, they're just taking more time to formulate their sentences and thus their fluency is a bit affected. Whereas on the other side, when we are discussing neurodevelopmental fluency, it is a disorder. And by disorder, we do mean that it's something that we need to uh, be attentive for. It's urgent and it does need evaluation and therapy. It is classified as a fluency disorder because it affects the rate of speech, the rhythm, and the effort during communication. So we might find our child stopping at certain sounds, prolonging them. We can see a bit of a tension on the face, and it's affecting the communication and the audibility and the fluency of the speech. The prevalence is 1% of the general population, and it's mostly seen in males than females. It's 4 to 1 ratio. How? How? How could we identify if my child has the normal developmental disfluency or does have stuttering and it does need clinical intervention? What we need to do is just to pinpoint at some of the core behaviors and the secondary behaviors in stuttering. The core behaviors are part of word repetitions such as ball, or sound prolongations such as sun, or silent blocks that would stop even the air inhalation and the sound from coming out. The secondary behaviors are learned, and it could be like blinking when it's stuck, or pushing a bit with the arm and the shoulder, or you can feel a bit of a tension here as well in the neck. So the child would jerk and move the head so that he can push the words out of their mouth. These behaviors and movements are related to tension patterns. These tension patterns are seen in respiratory and irregulation and breath holding, in laryngeal tension, and in articulation. Not only these visible signs are the characteristics of stuttering, we also have emotional reactions such as anxiety, frustration, avoidance to talk in public, reduce of willingness to communicate. So if you do see these signs in your children, then these are the signs that we look for in stuttering, and we do need to seek support. So here you would find a checklist. If just one of them is applied to your child, then you're good to go. That's enough for you as an indication to start speech and language therapy. If there's more, the messier. So we will have to go more than one therapeutical techniques in order to reduce this severity or this frequency of stuttering. So it's for you to weigh if this stuttering is affecting my child's speech and the listener is not comprehending what he's saying fluently, and it's effortful for him or her to produce, then these signs are enough for us to say that yes, we do have stuttering, and it's the time for us to consult someone specialist. Now, you might be asking me, why? Why does my child stutter? Why does it, what's the etiology behind it? Why are we facing this? The etiology is mostly genetic. 50 to 70% have strong hereditary components, and the rest, 20 to 30%, are differences in the brain structure and function. So we do see atypical activity in speech-related areas in the brain responsible for timing and coordination of speech. Thus, it's mainly neurological or genetic. Therefore, we have these types of stuttering. It's either genetic, and by genetic, it could be neurogenic with a neurological predisposition or factor, and psychogenic with a psychological trigger. In such uncertain times, psychogenic stuttering might arise because we have elements that are increasing our stress, trauma, fear, or any other emotional irregulation that is going to trigger the predisposition that we already have, and it's going to show the stuttering symptoms or even increase it. The other type of stuttering is developmental stuttering. By that, we already mean the children between 2 to 5 years that we have mentioned and talked about. These children usually fade the stuttering, and it goes after the age of 7. It disappears and doesn't get back. Whether if it persisted after that age, then we are discussing persistent stuttering, and in this case, it would continue with us during adulthood. The last type of stuttering is acquired stuttering, and this happens when all of a sudden in our adolescence or in our let's say geriatric phase, we do acquire stuttering due to a head trauma or side effect from a serious medication. We acquire the stutter. So the triggers that would increase or decrease the stutter are communication pressure, linguistic complexity, family dynamics, emotional status if we're anxious, excited, or fatigued, social context if we're speaking to someone in authority or in a public situation, and some individual variabilities that are tailored to each person's characteristics and personality. This is why these uncertain times would increase stress, anxiety, changes in routine, reduced sense of control, communication pressure, social environmental shifts. All of these are environmental and psychological factors that could either induce a stutter that hasn't been shown before, or it would increase the severity of a stutter that the child already had. So here we are. We can help. And by we, I mean the team. It could be either a speech and language therapist working solely and primary with the developmental or genetic stutter. If we do face a neurogenic stuttering, we will work collaboratively with a neurologist. And if it was a psychogenic stuttering with a psychological trigger, then we would work collaboratively with a psychologist. As a speech and language therapist, our assessment would be as follows. First, we would start with a case history. We take all of the details of the development of the child, and then we assess the child's speech. We take a sample and we count how many syllables, words did he stutter through all of this sample, and then we can, based on this, identify the frequency and the severity. If our child has only one type of stuttering, let's say it's only repetition of words like b, 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 then that's less severe than if the child has repetitions, blocks, and prolongations all together. It would create a complex profile. Thus, we will be needing to target each one of these stuttering types in our therapeutical plan. The behavioral analysis is also important. We would check if we have any physical tension, if the child is showing any grimaces or movements in the body in order to facilitate his speech flow. After our assessment, our therapy would usually take 2 phases or 2 stages. The first stage is with consistent attendance of 2 to 3 sessions a week, and it gradually fades. And then the second stage, we go for maintenance, 1 session a month, and we can increase that based on the need. Maintenance is important because stuttering is fluctuating due to these environmental factors. So that's why verbal contingencies should be learned by parents so that they can carry them over throughout their lifestyle. Some of the strategies that we know and we teach parents are preparatory set, easy onset, prolonged speech, pull-outs, cancellations, reduced rate, light articulatory contact, reducing filler words, continuous voicing and airflow, breath support, reducing word avoidance, relaxation techniques. I know that's a lot, and I have mentioned them on purpose because I really want to highlight the importance of working hand in hand with a therapist. Relaxation techniques and breathing exercises are most commonly known by parents as a treatment method for stuttering, but this is not the case. There are so many techniques, each for each and every type of stuttering, and there are so many multi-factors that a therapist should be targeting. But I will not leave you hanging. I will be providing you some tips and practices. So lend me your ears and let us put this into practice. Here is a diagram, and I have drawn this for you because we usually use it in therapy to explain the phases that we need to go through. So if you see the numbers, could you identify what would be the first step in our communication? What's the first thing that we need to do in order to speak or to produce a sound, which is resemble to this water tank? This is number one. If you have any ideas, please drop it in the chat. And I'll give you a hint. The flower at the end is our communication. So for our communication to bloom, for us to have proper communication, there are certain steps that we need to do first. 1, 2, 3, 4. Vocabularies. Other than that, okay. So the first step is actually taking a breath. So for us to produce a sound and vocalize anything, we need to have sufficient breath. Yes, that's breathing, correct. So breathing is the first step. We should have proper breath support that would support the sentence that we are elaborating. The second thing would be, what do you think? You have to think like it's etiology, like we breathe and then we have to vibrate the vocal cords. So after taking enough breath, the voice is here. Number two, this is the faucet that we turn on and so that the water would come down. If there is any blockage here, then the words would stuck. And this is what usually stutterers explain or suffer from. They say like, I feel that there's something stuck here. These are the vocal cords that vibrate and produce the sounds. And what about the third step? After producing the voice, we need to, any ideas? Articulate. Once the sound is produced, the tongue, jaw, lips, the cavity, oral cavity itself, we shape the sounds for it to become the letters that we do know right now, the sounds that we know. So the articulatory muscles should move, and this is where the water is shaped and it's drained from the pipe in order to number four the words to come out. So words would formulate, and here comes the vocabulary, Mr. Muhammad. Vocabulary is number four. We need to have our vocabulary straight, our language sorted out, our analysis is there so that our communication would come out fluently. And number five, the speech would and the communication would be fruitful. So I'm going to now explain and give you one exercise for each of these parts so that you can practice at home. The first one is breath support. So we have spoken a lot about diaphragmatic breathing and belly breathing, and I often see misconception in the clinic of its importance. And some people would simply ask me, what is my belly related to? How is it related to my breathing? The diaphragm is the line that you see below the lungs. Once we are breathing thoracically, we would see an elevation in our chest, like that. It's lifted up, and we only use this thoracic breathing when we are in an alert, we are crying, our body is in a tantrum, or we are doing a severe physical exercise. It's atypical for us to breathe from our chest, like thoracic breathing, when we are speaking or when we are at rest or when we are singing. This is the importance of the diaphragm to relax. Once this diaphragm relaxes, then here it would relax as well the abdomen, and the abdomen would inflate and expand. When it's expanded, it will leave much more room for our lungs to breathe and inhale in. That's why we don't see any visible changes in our chest, yet we breathe much more efficiently. So let's do a quick screening now and see who of us is able to breathe in from our abdomen and relax the diaphragm properly. We just have to put our hands on our chest, sit properly, and take a breath and check if our hands are elevated or not. In case your chest did elevate, then we need to develop further diaphragmatic breathing and work on our breathing. The second thing, as we've already mentioned, is our vocal folds. So for the vocal folds to vibrate, this is the way the vocal cords vibrate to produce a sound. It goes opening and closing quickly. When we are breathing or whispering like this, our vocal cords do not move. So they stay open and they do not actually touch. When we speak as such, our vocal cords should have proper contact and vibrate quickly so that they could create the sound. In such a case, some patients and children would experience some difficulties producing the glottal sounds. And unfortunately, it's there in O, A, E, I, in so many sounds. For us to facilitate this sound and reduce that feeling in our throat, that is, something's blocked, I feel tension here, and sometimes the voice just cuts off like this and I cannot continue the speech. This is why we need to work on our easy onset. Easy onset is adding a h sound before the word. So I'll give you an example. I want to say, I want. Okay, so we'll do it this way. Instead of going for I want, we will go for I want. We added a bit of an air that is easy for us, an easy onset. It opened the vocal cords and we avoided the glottal attack. This way, we would reduce the harsh contact of the vocal cords and we would avoid these glottal sounds that usually trigger our stuttering. The third thing to practice is articulatory muscles. When we are producing the sounds, most of the sounds are produced with our lips, tongue, and the jaw to form the other sounds. Sometimes we do add a bit more pressure on the sounds and then the sounds get blocked, like but. So in such a case, we need to work on soft contact technique. By that, we will also add the easy onset that we have previously done, sound, and then instead of producing the word with a very stiff and with a lot of pressure, we will add the easy onset sound, the h sound, and glide the sounds out like this. But, but. You just practice it as you go and you raise your volume until you find yourself comfortable with saying the h sound without it being audible. The second thing you do is you pull out the syllables that are stuck. If you're usually repeating the first sound like but in a word, the first sound in a word in a sentence, you just make sure and keep in mind to pull out the syllables on the vowel. So it's but, you make the a sound longer and you stretch the words a little bit longer. For example, instead of saying but I want, I'll say but I want. I'll make it a little bit longer and stretch the words so that I would not stop on the initial consonants. The last thing that we can do is also shorten our sentences. As we've mentioned, we do need a lot of breath support. So for us to speak fluently, we need to make sure that our speech is enough to the air that we already have and that we have already taken. So we took a breath and then we shortened the sentence to make sure we don't speak on residue of air. Speaking on air residue is not only going to trigger stuttering, but also it's going to abuse our vocal cords. So in such a way, instead of saying I want to go to the mall and buy some things, I'll say I want to go to the mall and I'd like to buy a few things. So just break your sentences into shorter sentences. Make sure that you inhale before each and every utterance. As for speech and communication, which is the last two things that we've spoken about in the diagram, it's very important to first clear out our ideas. Prepare what you're going to talk about, structure it, prepare your voice, make sure you're loud enough, you're opening, how you're going to start your topic, make sure you maintain eye contact and you have proper body language and the closure. Once you have everything analyzed and your language is processed, you know what you're going to talk about, you've prepared for it, and your child, if for example you're going to your nanny's house, you just informed them earlier, they know what they're going to do next. This kind of preparatory and planning will help reduce the stuttering in future. So we just take a few seconds more to respond. We formulate our sentences in our head before we speak them out, and we prepare if we have any presentation or an outing ahead of time. Now, all of these strategies are applied not only to adults, but also for kids. The only difference is that if your kid is stuttering, you just have to apply them yourself and model them. You can start with these tricks or tips as soon as the age of 2, as soon as you see the symptoms of stuttering. And by modeling, your child will learn how to slow down their rate, breathe in adequately, breathe from their abdomen, and do all of these techniques properly. Yet, I will give you some of the techniques that are dedicated for you and your children that you can use on a daily basis. First of all, we need to create a calm and an unhurried speaking environment. So, for example, you can put all of your schedule ahead of time, prepare it a day before, and then prepare some visual tokens or symbols that you can use and prepare for your child in the daily routine. And once your child finishes one of these tasks, you can remove it off the chart, and then the child knows what is next. This way of preparing the routine and putting it visually there in front of the child in a chart will prepare the child for what is going to come again ahead of him, and then it will reduce his anxiousness. You will also know what is next, so you don't have to be hurried. Everything is prepared, the environment is calm, and the child knows what to expect. If the child ever stutters during the day, what is supposed to happen is just listen actively and patiently. I know that it's sometimes hard for you to see your child having trouble to say the word, or you see the facial expressions on their voice or on their face, or sometimes it takes a lot of time for them to say the words. But what is best for you to do is just wait. Make sure you are close and you are at their level and you're maintaining eye contact. This is best for them so that they take their time and they do not focus on what they say, on how they say, rather on what they say. And this is what you should do. Respond to what they say, not how they say it. We don't want to raise um, we don't want to raise any concerns, or we don't want to show the child that they are stuttering. We don't want to pinpoint at it. We don't want to raise their awareness unless we give them the tools. So if you are asking your child to repeat and the child does not know the know-how, then you're only putting extra pressure on the child and affecting his emotional well-being. That's why it's important for you to collaborate with a speech language therapist, for her to be the one introducing stuttering, introducing the concept of having bumpy speech, and the how to fix it. So model good speaking habits instead. Give them the right response. Respond to them slowly with short phrases, with an intonation, and using a breathy voice that is calm and with a little bit of hairasm instead of going for the gluts and the hard eyes that they do. Just model it, and then through modeling, they will get the techniques automatically. Reduce questioning. If the child is having a severe time and he's stuttering too much, yet we're not going to encourage them retrieving from society and sitting aside, not complying or not talking because they feel there's something wrong. We will encourage turn taking and equal participation. You just have to choose the right time. When the severity is high and the stuttering is high, reduce the level of demands on verbal communication. Just have a quick, direct questions instead of open-ended questions, and encourage turn taking in other situations. Now, at school, if you want, you can just give the teachers some recommendations. For instance, to ask them a question, but give another child the turn first and inform them that they will answer next. This is going to give them the time to prepare and to be emotionally ready to respond so that they can also take turns and participate. Other strategies would be building self-confidence and positive self-image. When the children start to stutter, they might start to avoid social situations if they are self-aware. So what we need to do is pinpoint at the things that they already do very well. Like, wow, you draw very well. Wow, you're such a helpful child. You are supporting your friends. You are sharing with them. Just pinpoint at all of the positive traits that they have to keep that positive self-image and um, help the child see the value in their own character. It's not in the way how we speak. Now, if the child opens up and talks about stuttering, and that is not already tackled by a speech therapist earlier, let's say they are 6 or 7 years old, and until now we haven't gone through therapy and the child is asking about it, you just have to validate. We don't say, no, it's nothing, it will go, or I know, but you can do it. It's not a big deal. We just have to validate. If they say, it's stuck, it's hard for me. Yes, I know it can be sometimes hard. You feel it's stuck here. Okay, let's practice. What about we go to a teacher and she would help us practice how we speak fluently. Validate what they feel and just give them practical steps to follow would help them build their self-confidence on their own and know that they can earn this and they can do it through effort. It's not something that we deny and then avoid and it's gonna go on its own. That's why we should validate it and give some practical steps for them and encourage them to do it together. This is why the collaboration with a speech and language therapist is a must. And we should learn. Come inside the therapy session with us, see the techniques that we are using, see how we are implementing it, see in what stage your child is currently at. Perhaps they are now and stage 1 and they are not able to maintain it, they are not able to use it and during the whole day, so we will not request the child to have a 1 or 2 rate in stuttering over 9, so we just expect for now 5 or 6. So you should know, we should grade it together, we should apply the strategies in-house and here based on the stage that the child is currently at. Support his emotional well-being. If you see any signs that of negative talk about self, about the way they are speaking or anything, just consult. We can help. Psychologists can support through play, through drawing, even if they are very young. When they draw, they express in colors, in the pressure that they put, in the shapes that they are drawing. Everything can be seen through play as well. It will support their emotional well-being early on and it will reduce the effect on the stuttering. Last but not least, enrich their language and their development, since language and analyzing language, processing language is highly related to stuttering. We need to prepare, we need to have a good complexity in language so that we can elaborate, and then we are not thinking on what to say, only on the how to say it, and it will reduce a lot of the stutter. Now, the last thing to discuss is some questions that I received from parents. And after that, I'll leave some time for us to chit chat if you have any questions. Some questions that I hear of are, will my child outgrow stuttering? And the answer is unknown. If the child is 2 years old, then yes, 60 to 80% of the children do get reach fluent speech by the age of 7. But if it's above that age, then there are some factors to consider that it might go for a persistent stutter instead of a developmental stutter. Is stuttering caused by parenting? No, but environmental factors, as mentioned before, either increase or decrease the severity of the stutter. So it does play a role, but it's not the cause of it. It goes away and it just comes back. What should I do? You're frustrated about it. Well, this is how stuttering goes. It's a wave, it comes and goes. So you just have to have the means and the tools for you to utilize them wherever it comes back during stressful situations to protect you and guard you from a very severe stutter. And will my child be able to speak in public? Yes, they could with proper practice and training. And when should therapy begin? As early as can be. As soon as you see the signs and the symptoms that I have mentioned, then yes, we can start with therapy as early as 2 years old. This is it for me. These are the resources. Thank you for your attention, and I welcome your questions and discussions if you have any. Yes, these exercises can be used with adults. We just explain further, we go into the techniques and the psychology behind it, and we just go through a lot of more of the diagrams, and even we can go for relaxation techniques that would help. So it does apply to adults as well as children. Children is more of a modeling through indirect environments and play rather than discussions and exercises. Any other questions? Okay, so we have one more question. It's what parental responses can unintentionally worsen stuttering? Any pressure that we put on the child, like say it again. Oh no, that was too bumpy. You stopped. Can you try again? Or for example, repeating. Some children, it doesn't have to be only parents. Children would imitate them. This all will worsen the stuttering unintentionally. So adding any requests, asking the child to repeat after you, or just raising the awareness to it in an indirect way could harm, even if we don't intend that, unfortunately, as parents. Without the means, we shouldn't raise any awareness to it. Without the know-hows, the techniques, the strategies, it's better to just disregard it and only model. And if we do see it's persistent, then we go consult a professional. We see a speech language therapist. Thank you so much. Any other questions? Okay. Thank you so much. Oh, we have one more. How do I distinguish if it's true stuttering or maybe a shy child, stressed or anxious? Okay. Good question. So, as we've mentioned earlier, that there are some developmental stuttering that goes between 2 to 5, and then it's typically fluency related because of the language outburst. It could be stress and anxiousness as well, but if it's a stuttering, it's a disorder, it's not a disfluency, then you would see all symptoms. You should see the core behaviors and the core symptoms, which are stops, but repetitions like but, and prolongations, but, or so that's a prolongation. So if you see these three signs, or even one of them, with a little bit of facial tension or glottal or movement or jerk in the body, then it's a stutter. Even if it's stress, driven or anxiousness, because these are correlated. It could be psychogenic stuttering. So stress would play a great variable in inducing and increasing the severity of the stutter. But if that's not the case, it's mere disfluency and it goes on its own, and we don't see all of these symptoms. We just see some rehearsals like I want to go home, or I think we should do this. This is a normal disfluency. It's not a stutter. Anything else? Okay, so thank you so much for listening. I'm going to conclude. Thank you for your questions and your interactions. I would really appreciate if you would give us a feedback, and if you want us to discuss any other topic in future, you can also include this in this link. Either click the link or scan the QR code so that we can read your valuable input and feedback. Thank you so much for today, and we hope that we could support you in future. Bye bye.